Warm welcome on the second day of this AIOC. We are here to present our instruction course on general ophthalmologists. Generally, in their OPD, see lot of lumps and bumps, lot of tumors, and many of the times they don't realize which one to be referred, which one they can treat at their own level, and it becomes a dilemma in front of them as each and every patient comes with a different kind of a lesions from eyelid to the retina. So we are trying to cover the general overview of all the tumors from eyelids to retina, choroid. To do this, I have five of my colleagues with me, and to begin with, we have Dr. Puneet Jain. Dr. Puneet Jain did his MD from AIMS and fellowship from CFS with Dr. Santosh Onawar sir, and he is presently senior consultant in the heading the Department of Oculoplastic, Ocular Oncology at Sharp Side chain of hospitals in Delhi. Over to Dr. Puneet, please. He will be talking on the eyelid lumps and bumps, mainly the benign ones. Yes, please.
Thank you, Dr. Sumeet, for kind introduction. So we're going to start with the benign eyelid tumors. The slides have been so made that the focus of the entire PPT would be on clinical examination and diagnosis, and we will not be going into the details of histopathology.
Sorry to interrupt. So since this is a small hall and we wanted to make it interactive, in case if you feel there is any doubt, you want to ask something, you can just stop us in between us. You don't have to wait till we finish and everything. Let's make it interactive. If you have any cases, any pictures, we are more than happy to help you out with the same.
All right. So this is a broad list of benign eyelid tumors. We try to cover as many as possible, the common ones, the important ones, in the allotted time. So let's start with the epidermis tumors. So squamous papilloma is a very straightforward diagnosis. Usually refer to the oculoplastic clinic, especially if they are multiple with a diagnosis of warts. They can be sessile or pedunculated, and the management is pretty easy. The large ones can be easily excised with the help of RF cautery, and they bear no malignant potential whatsoever. Coming to seborrheic keratosis, also known as seborrheic wart, a very typical stuck-on appearance. You have a dirty-looking irregular surface, and histopathologically they can be of 6 types. Management again is, it can either be observation, but patient usually wants treatment, especially in these lesions which are located at the eyelid margin. Removal is easy. You can just shave these lesions off, and they do very well. They again have no malignant potential. So this is how the patient would look the next day once you do a shave excision of a seborrheic keratosis. Another patient with fierce looking lesion, again a very benign seborrheic keratosis, and this is how the patient looks 15 minutes later after you shave off the excision with RF cautery. So the surgery is pretty straightforward, short and painless. Inverted follicular keratosis is usually seen in middle to older age patients. The term was introduced in 1954 because it was believed that it is a hair follicle origin, but it's an epidermis tumor. It's a discrete nodule, and treatment is the same as the previous 2 lesions, and it bears no malignant potential. Pseudoepitheliomatous hyperplasia, as with ocular surface, is a benign pseudoneoplastic entity. It mimics basal cell carcinoma and squamous cell carcinoma histopathologically, and the management is on the lines of an eyelid malignancy. Keratoacanthoma, very typical lesion, usually solitary, can be multiple as well. This pit at the center usually gives away the diagnosis. Surgical excision is again on the lines of as would be with an eyelid malignancy. Incision biopsy, if planned for large lesions, should be done from the heaped up edges and not from the center of the lesion to get viable, histopathologically viable cells. Again, now the last but not the least is non-specific keratotic lesions. So any hyperkeratotic eyelid lesion which doesn't fall into the category of the previously discussed lesions would fall into this category, and it could be as simple as a cutaneous horn as seen in this picture. So don't be alarmed by such lesions. They might have some telangiectatic vessels at the base, which would be the reason for referral to the plastic clinic as a query sebaceous gland carcinoma or some random diagnosis, which I don't blame anybody for, but then we can diagnose them in our clinic and not create anxiety in the minds of the patient because once you tell it could be cancer or malignancy, then the entire scenario changes, especially if you are in private practice, and it becomes very difficult to go back to a benign tumor, though it is very benign. Coming to the next category, sebaceous gland tumors, one must remember the sebaceous glands in the eyelid area. So in addition to the Meibomian glands, there are also the glands of Zeiss, which are located at the base of the lash follicle. Now, when it comes to benign sebaceous gland tumors, we do see sebaceous adenoma and hyperplasia in the practice, but it's very rare, and usually this category would involve malignant sebaceous gland carcinomas, which would be discussed subsequently in the instruction course. Coming to sweat gland tumors, syringoma is very common. They usually not diagnosed, and patient is never referred to the oculoplastic clinic because it is very mild looking, benign, looks like a dermatological condition. They can be single or multiple. They are usually the same color as the adjacent skin. They tend to be more common in females. They tend to be bilateral and usually involve the lower lids, but can also involve the upper lids and can also be seen in male patients. The management is observation. If there is a standout larger lesion, then you can go for excision. The lesion bears no malignant potential, but do remember that they tend to recur and can exhibit aggressive behavior. So it's like poking the lion in the den. So just make sure that you counsel your patient if you do take the patient for any surgical procedure. Eccrine apospiroma, also known by a lot of fancy names, which have no clinical relevance. They usually arise from the duct and the secretory coil of the eccrine sweat glands. See, all these lesions clinically would look very similar. You could call this an inflamed sebaceous gland, sebaceous cyst. You could call this, it could be a lot of clinical lesions which could mimic this, and eventually the diagnosis would be histopathological. Again, the treatment is excision and the prognosis remains excellent. Sometimes these tumors can have a large cystic component as well, which would confuse the clinical diagnosis. Pleomorphic adenoma, we all know, is a benign mixed tumor. Usually we associated that with lacrimal gland, but it can also be seen in the eyelids. When it arises from the apocrine glands of the skin, it is usually called choroid syringoma. Like with the tumors of the lacrimal gland, it can undergo malignant transformation into a pleomorphic adenocarcinoma. So usually seen as a non-tender subcutaneous slowly enlarging mass, and complete removal gives excellent prognosis. Coming to the hair follicle tumors, trichoepithelioma, again a benign tumor, rises from the basal cells of the hair follicles, usually seen in early adulthood, and is a dome-shaped papule, but can have encrustations on the surface, and larger ones can be associated with telangiectatic blood vessels, which may resemble basal cell carcinoma. But remember, a trichoepithelioma is benign and it never ulcerates. Multifocal variants can be seen, and it's called Brooks tumor. Single lesion can be easily excised. Multiple lesions can be treated with CO2 laser. Trichofolliculoma, very characteristic picture taken from Shields atlas. You see a well-defined lid margin lesion with a characteristic central pore through which you can have cotton-like fine hairs as seen in the picture, or can have white lanugo hair protruding. This is a very good clinical diagnostic picture and is a giveaway diagnosis. You can easily remove this tumor with surgery. Pilomatrixoma, so any child presenting with a similar picture as shown in this slide, the diagnosis would be a dermoid. So again, it is impossible to differentiate this clinically. If you get imaging done and if it is not adherent to the underlying suture, then the diagnosis would be histopathological. You excise the lesion, the surgical management with the same lines. You give a subbrow incision like in this child, and you take out the tumor and send it for biopsy. These are very easy to manage. Coming to melanocytic tumors, nevi, they come in all shapes and sizes. So one has to remember that acquired type begins in the childhood and usually begins in the basal epithelium, when it's called the junctional nevus, and it gradually migrates to the dermis in young adults, where it becomes the compound nevus, and later it can entirely reside in the dermis when it's called the dermal nevus. So this is basically progression or natural history of the nevus, and depending on what stage you are excising, you get similar histopathological findings as well. So they can be deeply pigmented, they can be amelanotic. Amelanotic nevus usually mimics a papilloma. They can extend beyond the lid margin and spill over to the palpebral conjunctiva. Please don't worry about this. This is the nature of the benign lesion itself, and it does not indicate malignancy whatsoever. So these patients are again referred with a diagnosis of query melanoma, and again it becomes very difficult to take the patient back in time. So please, please choose your words carefully while you refer patients, because otherwise it becomes very difficult to. Clinically it is easy to manage, but psychologically it becomes very difficult to manage. So they usually do not cause any loss of cilia. So you would see the cilia would run through the lesion through and through. There might be misdirected cilia in the lesion, but sometimes they can, split the cilia and cause a an apparent sparseness in the eyelid. Again, that is not a feature of malignancy, and is after all a benign lesion. Now this is can be peripunctal, not very commonly seen. You can see the pouting of the punctum, and the lesion is still very well defined. You can easily excise this and put a mini monoca tube, and the patient would not have epiphora, and the tumor would be gone. Another variant is the kissing nevus. So the nevus develops before the eyelids divide during eyelid development. So when the patient closes the eye, the nevi come together, hence the name. These are very unsightly looking lesions, and patients are very concerned, and these can be easily managed with burning the surface with RF cautery. You can do it as a two-stage procedure also, wherein you can manage the lower lid and one lid first, and then 4 to 6 weeks after it has epithelialized, you can manage the other lid. So nevi are very easy to manage. Shave excision is very easy. There is usually no defect in the lid margin, and there is no loss of cilia as well. Another patient, this is how the patient would look on table 10 minutes after the excision with the cautery, and eventually the next day already you can see that the lesion is epithelialized. Again, a very fierce looking lesion managed with radio frequency knife, and you see that how beautifully the lesion heals. You can barely make out that there was anything. This is a 3 weeks picture post-op, and you see that obviously the patient is very happy. Coming to the last bit, nevus of Ota, it is oculodermal melanocytosis. This is how the patient usually presents. They tend to follow the distribution of the first and the second division of the trigeminal nerve, which would be similar to port wine stain. It can be bilateral also in 10% of the cases. Another association of this is iris mammalation, so one should be doing a good slit lamp examination as well. Patient should be evaluated should undergo a dilated fundus examination in any patient of nevus of Ota to rule out any uveal melanoma. Management is usually periodic. You can consult a dermatologist if the patient is too keen on cosmesis. Coming to vascular tumors, congenital capillary hemangioma, they again come in a lot of shapes and sizes. The good thing is that it's a benign tumor, one of the most common tumors of infancy when it comes to the eyelids. Usually apparent at birth, or becomes visible few weeks after birth. It can be superficial, it can be deep, it could be both components. Systemic association is Kazabek-Meretz syndrome, and one should keep that in mind. A good thing is that they progressively enlarge, but they tend to regress. So as a rule, 30% would regress by 3 years, 40% would regress by 4 years, and so on. And almost complete regression is usually seen by the age of 5 years. So in small lesions which are not causing any visual symptoms, no risk of astigmatic amblyopia, no visual axis obstruction, then you can easily observe these lesions for spontaneous regression, and they do not leave behind any cosmetic defect once the regression occurs. So this is how a deep one would look. They tend to be a little bluish, which is why they are referred with some other diagnosis, but they are dark in color because obviously they are deep seated, so hence the bluish hue. The natural course remains the same, and sometimes patient can have both superficial and deep component. This child would require treatment because there is a clear obscuration of the visual axis, and the patient is at risk of developing amblyopia. Management will not go into details, but oral propranolol is the preferred agent these days. Corticosteroids also give good response in these tumors, and surgical management is always there. Acquired hemangioma, also called cherry hemangioma, seen later in life, very typical lesion, mulberry red shaped lesion on the lid. They tend to rapidly enlarge in pregnancy. The larger ones again can have a bluish hue, but once you surgically resect them, you can see that again red mulberry appearance, very classical often, acquired hemangioma. They can clinically mimic angiosarcoma or a pyogenic granuloma, especially if they are very small in size. Management is observation. You counsel the patient. If they are very superficial, they can bleed to trauma. So that is one thing that has to be kept in mind. And usually the excision is for cosmetic reasons, and the prognosis and the outcome is very good. Port wine stain or nevus flammeus is a congenital vascular lesion. Can be isolated or syndromic, usually associated with Serge-Weber syndrome or Crippleton-Oni syndrome. When associated with Serge-Weber syndrome, the patient would have this characteristic dilated episcleral vessels, which would give away the diagnosis, and the patient would need a glaucoma evaluation. Classically seen in the distribution of the trigeminal nerve can cross the midline sometimes in a very irregular pattern. So keep that in mind. They're usually very slow growing and can become nodular with age. In contrast to hemangioma of infancy, they do not regress. So please do not promise the patient that this is going to improve with age, and then the patient will keep visiting your clinic every year in the hope that they're going to reduce in size. That doesn't happen. Lymphangioma of the eyelid usually represents as an extension of an orbital lesion or extension from the facial lesions. So an imaging of the orbit is important in these patients. Isolated eyelid lymphangioma is very uncommon, so please keep that in mind. They usually do not become apparent till first and second decade of life. So sometimes, they can have these cysts which tend to bleed in the cavity, and then these are called chocolate cysts. So sometimes these chocolate cysts resolve, giving up, pseudo-appearance of regression of the lesion, but this is not true regression, and some form of treatment would be required, which would be in the form of either resection if it is a very well circumscribed tumor, surgical debulking, or sclerotherapy, which is usually used in orbital lymphangioma. Coming to neural tumors, can be solitary neurofibroma, can be localized neurofibroma, or can be plexiform neurofibroma. This is one picture taken from Shields Atlas. I would diagnose this patient if comes in the clinic or is on teleconsultation to be a chalazion. But then this is how a solitary neurofibroma looks and resembles a chalazion. Multiple neurofibromas are usually seen in neurofibromatosis 1. They have low malignant potential as well. Plexiform neurofibroma, we are all aware, these are very pathognomonic of neurofibromatosis 1, and this characteristic S-shaped lid deformity is usually seen. Let's skip these slides. Coming to the last bit, xanthelasma, very commonly seen, yellow stuck-on lesion. What is the difference between a xanthelasma and a xanthoma? When a xanthelasma takes tumorous proportion, it's called a xanthoma. So technically, they are the same lesions. The patients can be normal lipemic also, so don't always look for hyperlipidemia as the cause of xanthelasma. And but you need to get the patient evaluated and at least get a serum profile done to make sure that the patient is not harboring something else. These can be unilateral. They usually are bilateral and can be asymmetric, but they can be unilateral. They usually involve the upper lids, but can involve the lower lids as well. Coming to xanthogranuloma, this is a fleshy tan colored nodule, usually a histopathological diagnosis. These can be self-limiting, but because of the color of the lesion, it looks very inflamed. So the patients are usually very anxious on getting them treated. So I would excise them and send for histopathology. I have no experience in using intralesional steroids in xanthogranuloma. Coming to cystic lesions, acrine hydrocystoma, it is ductal retention cyst of acrine sweat gland. Basically, it is a lid margin cyst with a fancy name. Management is observation, or you can surgically excise this very easily. Just remember to take out the entire cyst and not puncture the cyst, because if the epithelial lining is there, it will recur. Apocrine hydrocystoma, simply it is a cyst of gland of mole, complete surgical excision. They usually light up if you do a proper slit lamp examination. They light up like light bulb, so that's a giveaway diagnosis. Sebaceous cyst, again, they come in lots of sizes. You can have a comedonic center in the lesion, which sometimes can confuse you as whether it is something else. Treatment again is simple. You excise them with radio frequency. It's a 10-minute procedure. Epidermal inclusion cysts, these also similar looking lesions, usually on the lid margin, can easily be excised. Dermoid cysts, just for the sake of completion, because these usually would present as eyelid mass. It is not an eyelid mass technically. They usually commonly seen in the supratemporal quadrant in association with the zygomatico frontal suture, and can be easily managed with surgery. Last bit, chalazion we all know is a lipogranulomatous inflammation, usually arises from the moving gland in the tarsus, but can also arise from sebaceous glands of the eyes. It is a non-infectious obstruction of the duct. Please do not diagnose the patient without averting the lid. These patients can have partial burst chalazion, wherein the patient would be referred with a diagnosis of querysome malignancy or mass. This is nothing but body's way of sealing the inflammation. So if it ruptures inside, the body makes tissue, which is misnomer is pyogenic granuloma. It is basically healing tissue or granulation tissue, and one should be mindful of that. So this looks like a chalazion, right? It is a chalazion. This also looks like a chalazion, but it is not a chalazion. So always remember, see in a world where a lot of teleconsultations happen, at least in our practice, where people would send you pictures and then you just tell them, oh, this is chalazion, you can do this, and then you get a call from the OT, oh, this is not chalazion. So instead of intraoperative surprises and increasing your heart rate, might as well avert the lid in the OPD and just make sure that it is not a sebaceous gland carcinoma. This is a sebaceous gland carcinoma involving more than half of the lid and would require to be managed appropriately. So since I happened to come across this patient last year, so I put this as well, lipoid proteinosis. I remember this diagnosis from my Oculoplastic WhatsApp group 3 years back when Dr. Sonal had posted a picture. Somebody had posted a picture and she had diagnosed it, and that is when I first read about it and I got an opportunity to see a patient last year. It is not that common. So these are referred to as to us as non-resolving blepharitis, and this is called moniliform blepharosis, and systemic workup should be done for especially ENT examination, and the patient could be a case of Urbach-Wietz syndrome. So just keep that in mind as well. Thank you so much.
Thank you, Puneet, for that extensive atlas of all the eyelid lesions. Just to make it simple, all this benign lesion, 99% can be managed by everyone, unless there is a dilemma in diagnosis or management, but most of them can be managed by each and every general ophthalmologist. Now I'll be talking about the ocular surface lesions. Puneet, you can go ahead. Hello. Yeah. So I'll be talking about the ocular surface lesions. So when we want to talk, there is a wide array of pictures, atlas, and most of them you must have seen and maybe diagnosed, maybe undiagnosed. The most important take home from my whole presentation should be that at the end of presentation, most of you should be able to diagnose which are the lesions which are easy, which are only good or bad, and that can be managed at everyone's level, and which are the ugly lesions which you need to refer. So this is one of my favorite slide where there are this lesion, they are almost similar looking to each other, and if they come separately, then we might diagnose everyone as a pterygium or some kind of inflammation. But when all of them are in front of you, then you know there is something different. So I will not increase the suspense beyond this. I will just tell you this is one is actinic keratosis, other is pseudoepitheliomatous hyperplasia, and third is OSSN. Now whenever you get two similar lesions, the best way is try to talk about the lesion and describe the lesion. It will make your life easy. So whenever you want to find the difference between two similar pictures, go from left to right, and of course you will find the difference. So let's begin our journey of identifying which are good lesions, which are bad, and which are ugly. So first we'll talk about the good lesion, and which is of course more compared to the rest of it. So when I show you this different kind of pigmented lesion, let's start with the most common one. A 17-year-old female comes to your OPD with this kind of a mass, and she has obvious complaints that it is increasing in size and it is also causing discoloration. So with what confidence you can tell her that this is just an EVAS and you don't have to worry and this will not harm you anyway for your life? For that you need to see there is certain checklist which you should not miss at all in this kind of a lesion. So this appears first or the second decade of life, which is common. This is not congenital. This is majorly in the interpalpebral area. there are feeder vessel, there is intrinsic vascularization. It does grow. Nevus is not something that should be stable in size, and it will have a variable pigmentation. It will be light brown, dark brown to black to a certain extent. It will not be a single color. And sometimes when you cannot see the cyst properly, then you can of course do ASOC2 to ASOCT to document that there are cysts and it is not encroaching on the cornea. So these are very clear features which differentiate your nevus from anything else. Now since we have learned about nevus, let's put one more picture in front of you. Again, this is a 28-year-old male with good vision and coming with the same complaint that this mass is growing. Now let's dissect this mass properly, and we see this mass as a two component, one the upper component and one the lower component. We are not bothered about the upper because it is showing good features, it is showing cyst, everything, and it is falling in the diagnosis what we have seen in our last slide. Now what about this? When we are seeing this part is little not so nevus kind what we differentiated. So what is so much different than the nevus? So this is away from the limbus. Okay, this was not there in the checklist. This is involving caruncle, not in the checklist. Cysts are not seen here. The pigmentation is too much dark and the margins also are not very clear. Now we need to differentiate that are we looking at a good lesion or are we looking at the bad lesion? What do we do in such cases? Again, there is a simple checklist that which nevus you should excise and which nevus you can observe. So there are certain indications which are there, and let's have a checklist again. If there is a nevus without cyst, of course our lesion is without cyst, especially the near the caruncle one. Nevus which is more than 1 centimeter, of course our lesion is much larger than that. A lesion which is very much uniform dark pigmentation, it is showing that it is turning into a malignant one and it is involving cornea. So all these lesions, all these points tell that you need to excise this nevus. So we will excise this part of the nevus, did an incision biopsy, and that showed that this is turning out to be a melanoma. So nevus can turn out into a melanoma, and then we had to do excision biopsy and go further. So any nevus you are observing, you need to be very careful and keep watching it and tell the patient. Most of the nevus patient will come to you with the cosmetic blemish, and of course for the cosmetic reason also you can remove the nevus. How many of you have seen this nevus very often in your OPD and excised as well? How many of you excised the nevus? Yeah, very much. And what was the indication? Cosmetic. Observation, correct. So the cosmetic is something that will come most often to you, but the size is something that you need to look after. Now coming to this lesion, again this looks quite a benign pigmented lesion, but this is not a conjunctival pigmentation, this is a UVL episcleral pigmentation, and this is nothing but what we call it as a congenital ocular melanosis. Why these lesions are important? Generally 2-3 year old patients might come to you with this kind of a lesion that there is some pigmentation happening. You need to dilate this patient once in a year to see the retina properly, because they 1 in a 400 have a risk of having a UVL mass in such cases. Of course, you do look for hairline pigmentation and palatal pigmentation because this is a congenital mass and the pigmentation could be anywhere. Now, out of all the lesions that I am describing today, this is the most common, especially those who practice in the rural areas. You see this kind of a variable pigmentation around the limbus 360 degree, but this is something not to be worried about. Once you see this one eye, always see the other eye and you will have this a bilateral. The most important feature of differentiating complexion related conjunctival pigmentation that it is a bilateral lesion. Now coming to next, what is it? Like I had shown this in a very first slide, this looks not so a healthy lesion, but this is just a reactive inflammatory proliferation. This is conjunctival pseudoepitheliomatous hyperplasia, more of a histopathological diagnosis than it sounds to be a clinical diagnosis. Why it happens? Generally secondary irritation could be because of some surface inflammation, some sutures post-pterygium surgery, some foreign body not completely removed. All this can cause hyperplasia of the epithelium. And how to treat? Again, a simple excision is the way to go in such cases. And run through few lesions which are not so common. These are inclusion cysts, especially in the fornical and the caruncle area. They have a high amount of vascularity, but they are very much benign and they can be easily excised. Now, what kind of lesion is this? This was one of the shown by Puneet. This is capillary hemangioma. Again, having a conjunctival hemangioma is rare. It generally comes from the orbit of the eyelid and then it comes to the surface. The propranolol is the way to treat. Now, what is this happening? A cactus growing near Eiffel Tower? No, these are choriostomas. And 5 choriostomas which everyone must be aware of. And these are the pictures. I think most of them must be seen by you. The most common ones are the first and the third. Dermoid is what we see most commonly. Dermoid comes with the 3 different types, where it is either growing partially on the cornea or fully on the cornea, and the in-between variety. So these partial ones do encroach on the cornea, but there is only lamellar involvement of the cornea up to 100 to 200 microns. So they can be easily tackled without doing any lamellar keratoplasty, but don't be overzealous while dissecting it. Lipodermoid, again common, generally never comes into the site. The one important point when you're excising this kind of lipodermoid is be careful with the lateral rectus muscle. Secondly, don't be overzealous that I want to remove the whole of the fat and I will just make the patient fatless. That is not going to happen because it is going to come from the orbit. So remove only what is necessary and the rest you can just reconstruct putting the AMG there. Don't try to remove the whole of the fat from the lipodermoid. Others are rare, which is osseous choriostoma, complex choriostoma and lacrimal gland choriostomas. All this we discussed were the good lesions. Now let's go to the bad ones. Now you see this kind of lesion very often, and like I told you, when you see this kind of a lesion, you need to see the other eye, but you will find the other eye may be normal. This was called as a PAM, primary acquired melanosis, which nowadays they call it as intraepithelial melanocytic proliferation. Again a pathologist term. This generally manifests in the middle age, unilateral, superficial, solitary, patchy, diffuse, multifocal, and it could be anywhere on the conjunctiva. These are the lesions you need to be worried about. When do you need to worry about? These are the 4 conditions of the PAM you need to be worried about. First, it is growing more than 5 millimeter. Secondly, it is involving cornea. Thirdly, there is a history of melanoma anywhere else in the body. And you are seeing the patient over a years or years together and you see that there is a pigmentation and increase in the mass. That is the time that you do a biopsy for the PAM to see that it is with the typical changes or not. Depends on that, the rest of the treatment goes on. Now this is again a very simple looking lesion. Many of the times we say write it as a pinguicula. Go ahead and put patient on the tear substitute. These are basically actinic keratosis. These are pre-malignant lesions. You need to observe if it comes with the recurrent inflammations to you. Otherwise, you can simply observe and keep the patient on the regular follow-up. Excising is not a difficult issue here. Now coming to the ugly lesions. Now you see this kind of a lesion. I had gave you the glimpse of the same when I was talking you about the nevus part. Your nevus, which is darkly pigmented, growing on the cornea, feeder vessel, crossing Earth's boundary, it is nothing but a conjunctival melanoma. Conjunctival melanoma, it is most commonly comes from your PAM. So whenever you are seeing PAM, do be suspicious about it growing into a melanoma. From the nevus, 20% of it and 5% de novo. Older age, thicker base, no cyst and the hemorrhage are most important things which will help you to differentiate your nevi lesion from your melanomas. Now again the first slide I am showing you. When you see this kind of a picture, like I told you, you see a surface lesion or any lesion, try to describe. So I will describe it for you. Describe in terms of location and the growth. It is on the bulbar conjunctiva near the limbus, growing on the cornea. There are feeder vessel, there is a keratin, there is a intrinsic vascularity, and there is a rose Bengal staining. If you see a surface lesion, if you see a pterygium, and you have even a smallest of doubt that it is not fitting into what you see on daily OPDs, please think that this is not a pterygium and something else that you are looking at. And these are the 4 points which will help you to differentiate your pterygium from your OSSN. This is nothing but a ocular surface squamous neoplasia. How do you treat? There are various treatment options. Observation is out of box. Excision biopsy, chemotherapy, radiation, exenteration, all these are different features. Now I will not go into details of this, I will just show you in a brief. This is all four are ocular surface neoplasia and all of them are treated, and these are post-treatment pictures. And these are the various way we treated them. The first is surgical, second is interferon, third is excision plus radiation, fourth is chemotherapy. So just briefly to tell you, the first lesion is very small, here it is. And this can be very well excised if you know the patient is not going to come to follow up. This is a very wide one which you cannot excise because the whole cornea is involved. Here giving a chemotherapy makes sense because it is involving more than 6 quadrants of your conjunctiva. This third nodular lesion has equal amount of the base, and this also involves your sclera. You cannot remove the whole sclera and do a scleral patch graft. Here your radiation comes into picture. And the fourth one, like I told you, can be treated completely with the interferon or 5-fluorouracil, whatever it is available in your town. So when we see that we know everything about OSSN, I would like to keep a picture in front of you that this is a patient getting treated with as scleritis, and patient is on steroids. There is no improvement, there is no pain, all the workup for collagen vascular disease is negative, and patient's lesion is keep growing. You see any kind of ocular surface lesion, again not fitting into a common diagnosis which has been made by your previous colleague. Very simple thing that you do in your OPD is please do stain the lesion. Again, this is a masquerades the way the OSSN can present. Other most important tool everyone has in their OPD is doing a ASOCT whenever you feel in a doubt of a diagnosis of OSSN before you go ahead with the biopsy. And the third ugly lesion, just to give you a brief history again, a 50-year-old female comes with this kind of a pinkish mass which is not again resolving, no pain, not fitting into a picture of scleritis. What are you looking at is a diffuse, slightly elevated pinkish mass is basically could be a conjunctival lymphoma. It could be unilateral, it could be bilateral, and these are high chances that this get converted into a systemic lymphoma. So you need to be very careful with such lesions. So these three ugly lesions you should be very aware about: melanoma, OSSN and lymphoma. Rest, most of you can manage at your level. So when you have a different lesion like this, you just use the algorithm that we just discussed, describe the lesion, try to fit into one of the diagnoses, and just classify that as either a good, a bad one, or the ugly one. So to conclude, examine every conjunctival lesion carefully, document it properly, keep a high index of suspicion, and biopsy when needed. Please do that. I acknowledge my mentor, Dr. Santosh Onava sir, for teaching me everything that we discuss here, and thank you all for patient listening. I call upon Dr. Sonal for discussing the benign retinal and choroidal tumors here. Dr. Sonal did her fellowship with Dr. Santosh Onava sir, CFS Hyderabad. Then she was with Dr. Paul Finger, New York. She also has written one large open access book on all the tumors, which is very much available on the internet. And presently she is at HV Desai and she has her own center in the Pune. Welcome, Sonal.
Thank you, Dr. Sumeet, for the kind introduction. I think both of our prior speakers have opened up an atlas of eyelid and ocular surface tumors in front of you. So what I have done is I've chosen a few lesions which we commonly get to see in routine retinal examination. So the beauty, or the point of these lesions are they are hardly symptomatic. So hardly the patient is going to come to you with anything specific. These are the lesions you might just find while doing a complete examination, a complete dilated examination. So again, to reinforce the importance of a dilated fundus examination, even if the patient has come for an anterior segment complaint or just a routine workup. So ideally, the fundus examination has to happen annually for every individual. So that is when you get to spot these lesions, diagnose them, label them, and then monitor. Because more often than not, the treatment is going to be monitoring. So with that, let's go on to a few of these colored lesions. So most of these lesions I'm going to talk about are going to be pigmented. Where does the pigmentation come from in our intraocular tumors? So the primary intraocular pigmented lesions can be either from your melanocytes of uveal tract or from pigmented epithelium. So we are going to cover a few of these lesions, including congenital hypertrophic retinal epithelial, hypertrophy of retinal pigment epithelium, RP hematomas, a combined hematoma of RPE and retina, and optic nerve head melanocytoma. So basically, where does the pigmentation come from? Specifically, if you talk about retina, there can be atrophy of cells, hypertrophy of cells, or hyperplasia of the pigmented epithelial cells, which is going to give rise to these colored appearances. So either a migration, increase in number of these cells, or migration of these cells and metaplasia, or exaggerated hypertrophy and hyperplasia are going to give you these appearances. So this can either come from infections, post-infectious scarring, or tumors or trauma. So be careful while you're examining any pigmented lesion. Look at the associated features as well. So coming to a common entity, so we commonly call it as a CHOPY. This is a congenital hypertrophy of retinal pigment epithelium. So the common types it can be divided into are solitary, grouped, or multiple CHOPYs, and atypical ones which are known to be associated with familial adenopolis. So coming to solitary CHOPY. So this can be a well-demarcated, flat to minimally elevated plaque-like lesions, which can range from black homogeneous lesion, usually typically with a depigmented lacunae, to a completely depigmented or a full with lacunae lesion. So coming to a solitary CHOPY, so you will see the stuck-on appearance it is giving on the retina with very well-defined edges. Sometimes it looks like this as a completely pigmented lesion, or sometimes you can have these halos or lacunas, which is also a characteristic of the solitary CHOPYs. The common conditions this can be confused with is a peripheral choroidal nevus or choroidal melanoma. Those are the conditions you have to differentiate this from. So what puts this apart is these lesions are found mostly in the mid-periphery to periphery. And if you go on doing further investigations, you will definitely be able to differentiate it from nevus or melanoma. So these are congenital, though they are congenitally diagnosed, median age of diagnosis is around 45 years, because these are incidental findings in an asymptomatic patient present in mid-periphery or periphery. They can be well demarcated, minimally elevated, a homogeneous lesion, typical depigmented lacunae, which we just spoke about, can have slow gradual growth in its peripheral diameter. Though not alarming, but 2% of them can have a nodular growth, which can lead to an RP adenoma or adenocarcinoma in future. So how do we differentiate? So if you look at the ancillary testing commonly done for endosclerosis and angiography, you will be able to see the blocked fluorescence and retinal vessel crossing above it. Will help you differentiate it from the choroidal pathologies, which will kind of show their own vascularity as well. OCT will show loss of photoreceptors, the subretinal clefts, which we call, and increased transmission through the lacunae, which will help you label these lesions. So what will you do after labeling these lesions? The most commonly applied treatment is periodic observation. If you do have a lesion with a small nodular growth, if it has given rise to some exudation or subretinal fluid, laser photocoagulation or cryotherapy, because these lesions are far in periphery, will work well. Or if there is surface wrinkling, retinopathy, and a lesion representing macula, vision-threatening component, you can also add vitrectomy and membrane peeling for the same. So how about these ones? They are the multifocal or grouped CHOPYs, or beer tracks they are called, because of the small combined appearance. So these are several groups of well-defined flat slate gray lesions. They usually assume a sectoral distribution. They are present together. Each group can consist of around 3 to 30 individual of these pigmented lesions. The diameter can vary from 0.1 to around 3 millimeter. With the larger lesions located more peripherally, smaller lesions are located more centrally. But these tend to lack the lacunae which are present in a solitary choppy, can be minimally elevated. They can also be polar bear tracts, which are the non-pigmented lesions. So the entire sector can be non-pigmented. You can call them as a polar bear tracts, being white bears. These are essentially stable lesions. So which are the lesions you need to be concerned about? Though, Dr. Sumeet wanted me to cover the lesions not to be worried about, but everything, in every lesions you do need to be wary of some points. So these are the atypical ones which are associated with familial adenomatous polyposis and Gardner's syndrome. So 70% of patients with familial adenomatous polyposis can have these lesions. These are multiple and bilateral. How they differ from the classical choppies, they have less defined margins. They are randomly distributed, not sectoral in distribution. Can be pinpoint to more than 100 in number. So this condition has a strong association with FAP and an autosomal dominant condition in which 100% of the patients can develop colon cancer. So including the patient, the entire family needs to undergo routine colonoscopy to rule out any presence of polyps in their intestines. So again, management is periodic observation. Close association of FAP and colon cancer has to be kept in mind and reminded to the patients to keep under routine follow-up and systemic investigation. And as I described, the periodic colonoscopy and removal of suspicious polyps for individual or family is of utmost importance to avoid progression of the disease. Small note regarding RP hamartoma. So again, another incidental findings. You just might find them while routinely examining a fundus. These are distinct solitary nodules, can be less than 1 millimeter to 1 to 2 millimeter in diameter, and 1 to 2.5 millimeter elevation can also be there. So just because something has an elevation or something has a 3D configuration does not mean it has to be worrisome. These hamartomas can also have significant thickness. They tend to be in central macular location. Minimally dilated retinal feeder vessel and mild adjacent retinal traction and vitreous pigment cells are also been described in association with the RP hamartoma. So how can you examine it further is with the help of OCT. It will show an abruptly elevated solid mass within the retina and a complete optical shadowing because of the pigmented and solid nature of the disease. So the OCT helps in monitoring these lesions and exactly knowing which layer the disease has penetrated to, if at all there is any progression. Another interesting one is a combined hamartoma of retina and RP. This is also very important differential diagnosis of leukocoria when you are examining pediatric age group patients. So these tend to be congenital, non-hereditary. The diagnosing age might be around 10 to 14 years of age, depending upon where the lesion is situated, how much visual disturbance it has caused to seek medical attention. They can vary widely in size, ranging from small 1 millimeter diameter mass to lesion greater than 10 millimeter. So they tend to be these gray retinal masses that demonstrate tortuous and straightened retinal blood vessels, probably due to the secondary retinal traction from the excessive gliosis on the surface of the lesion. They are characteristically located along, on or adjacent to the optic disc. A peripheral lesion can also cause retinal dragging, creating a drag disc appearance. Such combined hamartomas can be associated with peripheral retinal ischemia and secondary peripheral neovascularization. They can be completely isolated. However, some association has been found with neurofibromatosis too because of the inherent gliosis these pathologies have in common, Gorlin syndrome as well as branchio-oculofacial syndrome. So if you go ahead and do a fundus fluorescein angiography, the dragged appearance and retinal traction bands are very, very visible. OCT will help show an irregular lesion with vitreoretinal traction into a sawtooth or a folded pattern as visible here. So that is what is replacing the entire thickness of the retinal tissue over here. So management-wise, there is no highly effective method for treating any of these lesions. For children, amblyoptic therapy can be helpful for vision restoration. A vitrectomy and membrane peeling can be helpful in cases with vitreous hemorrhage or a preretinal gliosis. But however, if the lesion involves the full thickness of retina, there is nothing much you can do about it. OCT can help determine the depth of the lesion and can help which patients may benefit from this intervention. However, rest need to be monitored for their presence. And the laser photocoagulation can be employed for rare neovascular membrane that can develop on top. Moving on to, I think, one of the last lesions. So this is an optic nerve head melanocytoma. So melanocytic hematoma or hyperpigmented magnocellular nevus of optic disc is the optic nerve head melanocytoma. Many a times get confused with the choroidal melanoma, or not confused, I would say. You need to differentiate it from choroidal melanoma, juxtapapillary choroidal melanoma. Because again, the treatment over here is going to be observation. So what I feel is observation and monitoring is actually the most difficult decision to make, because you're not intervening, you're not taking out any tissue, you're not doing anything. So you have to be really sure about your diagnosis before not doing anything about it. So always be thorough with the investigations. All of these lesions can be investigated thoroughly with ancillary testing available in all of the ophthalmology clinics. So these patients tend to be around 50 years of age averagely, can be unilateral, mostly unilateral. 25% patients can present with visual loss because of subretinal exudation or fovea, neuroretinitis or CRVO, or a malignant transformation which occurs in less than 1% of patients. They do present with RAPD very classically because of the optic nerve affection and also visual field defects. They can show growth over a period of time, so don't be alarmed just because there has been a growth. However, it needs to be a slower growth. The growth can be either on the retinal side or also on the optic nerve side, so periodic MRIs are also important. If you do a perimetry, you would find that these patients do have visual field defects and enlargement of their blind spot. So minimal to extensive enlargement is known to find. And a nerve fiber bundle defect related to absolute arcuate defect can also be found. On OCT, they tend to have this particular halo beneath the layers, and you can actually see small melanocytic cells being picturized in the perilesional vitreous. They do block fluorescence on FFA. So FFA, OCT and ultrasound B scan and periodic MRI can be the tools you use to periodically monitor these lesions. So again, periodic observation, small degree of growth can be observed. A more progressive growth or a profound visual loss or a probable malignant transformation, enucleation and histopathology is the way to go. So to summarize these lesions, you can look at the shape, color, number of these lesions, how they are placed and their borders, location, particularly macular and extramacular. That will give you a gross idea about how to label these lesions. So once you have examined, investigated and labeled these lesions, then you can go on monitoring and following up the same patients. So in interest of time, and I'll stop here on completing the retinal lesions, and I'll hand over to Dr. Mritika to take over for the malignant retinal lesions. Thank you.
Thank you so much, Dr. Sonal. And just till the Mritika sets in, I would like to ask, what do you do for those optic disc melanocytoma generally? How often you observe them, and what is the protocol that you follow?
Yeah, so the first at the first visit, you do a complete thorough examination, including your fundus imaging. So imaging and documentation is the key here, because that is how you're going to monitor them in the future. OCT, ultrasound, and an MRI is very, very important, and visual field, perimetry for visual fields. So I like to see them every 3 monthly for the first year, and repeat the perimetry every 6 monthly, and also give them a list of warning signs to come back in between the scheduled follow-ups if at all they notice any sudden change in vision or any other characteristics. And then later on, 6 monthly for another couple of years, and then can monitor yearly for any growth if at all seen. I think I have a few patients who are under monitoring, and they were all diagnosed very incidentally. So the only thing is, again, for your back of the mind diagnosis is ruling out choroidal melanoma. How much ever investigations you do, you still just need to have that little this thing of thread of suspicion, and look for any characteristic you find similarly. Thank you for the opportunity.
Now we have Dr. Mritika Sen. Dr. Mritika Sen did her MD from AIMS and a fellowship with Dr. Santosh Onava sir and Carol Shields from Philadelphia. Presently she is working at Shankar Nethralaya, Chennai, and she will be talking about the retinal tumors to be worried about. Over to Dr. Mritika.
Good morning everyone, and thank you Dr. Sumeet for including me in this IC. Dr. Sonal has already explained to you the lesions that you need not worry too much about, and I'll continue with the lesions that you need to worry about. There are some pictures which may be similar because we all come from the same family of Dr. Honavar, so we have the same source. All right, so I'll be taking you through the retinal lesions which you need to actually worry about. So choroidal nevus, we don't see them too often in our population, but when we do, we need to identify the ones that are at a risk of transformation into a melanoma. So how do we decide that? Although the risk is quite low, there are certain typical features that can help us identify the risk of a transformation, and that is with the help of a mnemonic which goes by TFSOM-DIM, and I'll explain that in the next slide. Also, nevi, they can grow, but it is the rate of growth that is important. Not every growth represents a malignant transformation. So coming to the mnemonic, T, it basically correlates the clinical features with the imaging features that can help you identify. So a thickness of more than 2 millimeter, that is on ultrasound, presence of subretinal fluid underneath or rather overlying or around the lesion, that is on OCT, visual acuity less than 20/50, presence of orange pigmentation, this is best appreciated on autofluorescence, and this is because of the presence of lipofuscin. And presence of melanoma hollow, that is again an ultrasound feature, and on fundus photography, a diameter greater than 5 millimeter. So presence of 3 or more of these features puts this patient at a relatively higher risk, and you would want to treat these lesions early. So this is a slide that kind of shows you the difference between a nevus and a small melanoma. If you look at this lesion, this is a relatively flat lesion. Of course, we will confirm that on ultrasound. But these lesions on top, these are drusens. Presence of drusens are basically indicative of a chronic lesion. On the other hand, when we look at this one, you can see the extensive amount of orange pigmentation that is overlying this lesion. In addition, you have a nodular component with a slightly greater thickness and most likely SRF associated with it. When we do an OCT, we are likely to find some amount of SRF. So this is a lesion that I would treat, and this I can keep under observation. So this is a small melanoma. Again, part of it can be pigmented, a part of it can be non-pigmented. On autofluorescence, the orange pigmentation is better defined, and there is subretinal fluid which also contributes to the poor vision. So in this case, this patient has 4 of the risk factors. So we would treat this lesion. Again, it is a combination of these factors. So when we have 4 or more features, as you can see that the risk of transformation into a melanoma is almost 50%. So this mnemonic or these imaging features are helpful in diagnosing small lesions or small melanoma. Of course, the larger ones, there is no doubt that it is a melanoma. So it's only for the small lesions where you have some doubt whether to observe or to treat that this comes into picture. Now I'll just take you through some of the pictures that show some of the manifestations or the presentations of choroidal melanoma. It can be a very small one like in this case. On the other hand, it can be large with overlying hemorrhage, or it can have a ciliary body component as well. This is the most common form where you have a large pigmented choroidal mass. Sometimes they can be amelanotic, in which case you can confuse them with a choroidal granuloma or a metastasis. As I said, that they can be a component which is pigmented and a component which is non-pigmented. Similarly, you can have lesions which can show a break through the Bruch's membrane, and that is because of the that can show a collar button or a mushroom appearance. Now, the important thing to remember in this case is when we treat them, we should remember that the base is always larger than the lesion that is visible as the mushroom shaped within the eye. So we have have to treat the entire base, and that is apparent on ultrasound. So we have to take the ultrasound measurement. And this can also have vitreous hemorrhage, which can actually preclude our view of the lesion. So here again, imaging plays an important role. So this is a hemangioblastoma. Why am I showing you this picture? Because you can see these dilated tortuous vessels, and so a hemangioblastoma will have a dilated feeder artery and a dilated tortuous draining vein. On the other hand, whenever we see a tortuous vessel, we should examine the periphery very carefully, because it can also harbor a melanoma at the periphery. So just like a sentinel vessel on the surface of the eye, where we always tell you to do a gonioscopy or a UBM, it's very important to indent and look for peripheral lesions. In case of melanoma, there won't be a feeder artery, but generally what is observed is just the dilated tortuous draining vein. Another type is the diffuse choroidal melanoma. These have large segments of pigmentation, and these tend to be rather extensive or rather aggressive, both moving extrasclerally as well as with their metastatic potential. They're not very thick, but you can see the extensive amount of orange pigmentation that is associated with it.
What is this then? This is called exorbitism. Whenever there is proptosis associated with a craniofacial anomaly, you call it exorbitism, where the etiology is a shallow orbit, and that is pseudoproptosis. The patient looks as if she has proptosis, but the reason is that she has high myopia and staphyloma in the left eye that is causing apparent proptosis. And in patients who have lid retraction, they may look as if they have proptosis, but the moment you correct the lid retraction, they look absolutely normal. So these are causes for pseudoproptosis. Now, these are the terminologies that we have learned, and assessment of proptosis also includes exophthalmometry, measurement of displacement, assessment of ocular motility, and on palpation you're supposed to do so many things. And finally, some special tests such as bend down test and Valsalva maneuver, look for pulsatile proptosis, look for periocular vascular changes and hemorrhages, etc. Periocular yellow lesions, which straight away give you the diagnosis of xanthogranuloma without having to do a biopsy. Then look for signs of neurofibromatosis. Remember to do all this. And finally, at CT and MRI, then you get to the diagnosis. So this is a laundry list of orbital tumors that we have. And if you look at the Indian epidemiological data, these are the most common tumors: lymphoproliferative, vascular, secondary, and cystic lesions. And depending on which part of the country that you're working in, you may have some difference in these etiologies. So let's start with congenital tumors or lesions. When a child is born and has a lesion like this, where you don't know what is happening to the eye, but there is an obvious orbital mass, and if it is bluish and if it's in the lower lid, you suspect colobomatous cyst, especially if the other eye has a triangulation sign. That means the cornea is not round but is slightly triangulated, and the pupil is drawn towards that. So that indicates that the child has fundus coloboma, and that straight away gives you the diagnosis of colobomatous cyst. The first thing that you do may be a CT, but then the ideal thing to do would be to prognosticate. Is there any vision possibility at or not? You do that by aspirating the cyst and inspecting the eye. If the eye has visual prognosis, sometimes eyes with 6-7 millimeter cornea can have visual prognosis, then you don't do sclerotherapy. You tend to excise the cyst, because sclerotherapeutic agent may enter into the eye through the communication and cause phthisis in a potentially seeing eye. Otherwise, you use sclerosing agents, which is already published. If a child has an orbital mass but you can't see the eye, then you do radiology. You find that there is a large cyst with one of the walls of the eye integrated with a periosteum. That generally happens on the temporal side. Then you call it congenital cystic eye. This can be eviscerated and the child can be cosmetically rehabilitated. But if the eye is nearly normal, but it is only pushed by a large lesion which is lying behind it, which is expanding by the day, then that is orbital teratoma. It could be benign or congenital, benign or malignant, and the malignant variant can have intraosseous extension, periocular hemorrhages, intracranial extension, etc., and that is how you suspect it. This was a benign orbital teratoma. You can, on radiology, you can see a fully grown tooth within it that confirms the diagnosis. These are some of the other causes for childhood proptosis or infantile proptosis. Capillary hemangioma of infancy with orbital extension. That's a variant of intraosseous hemangioma, where the hemangioma is localized to the bone. Just tell me when to stop, because the next session we start, right? Yeah. Now I'll go on to give differential diagnosis for proptosis based on age and location. If a child has axial proptosis, the most likely diagnosis would be optic nerve glioma. If a child has abaxial proptosis and that is subacute, then you consider rhabdomyosarcoma, leukemia, primitive neuroectodermal tumor, and alveolar soft part sarcoma. If a child has chronic proptosis, most likely it is lymphangioma or dermoid. Like a child like this, where there is subtle proptosis, axial proptosis, you suspect optic nerve glioma and look for caffeole spots, look for Lisch nodules, etc., the stigma of NF, and on radiology you find a prompt optic nerve lesion. This is bilateral proptosis in a child, axial, some amount of displacement, bilateral optic nerve glioma. Subacute abaxial proptosis, you find that the child has rhabdomyosarcoma. Again, a subacute abaxial proptosis, rhabdomyosarcoma. Now, if a child has solid chemosis like this, what? Okay, I'll stop. All right, thank you. No, that's fine. No, this is solid chemosis, this is angiosarcoma. Thank you so much. No problem.
So, thank you all for staying here without air condition and listening to all the talks. Thank you for all of being here. I I hand over the session to Dr. Chitra ma'am and Kumar sir for their next session.